Good afternoon, and welcome to COVID-19 Vaccine Access for Homebound Older Adults, Challenges and Solutions, hosted by Trust for America's Health, or TIFA for short. We would like to thank our speakers and audience for being with us today. For today's webinar, audio will be accessed through your computer speakers or headphones. Next slide, please. And again to the next. We encourage you all to share your thoughts and questions about today's presentation by typing them into the Q&A box. We'll try to answer as many as we can as time permits. To open the Q&A box panel, click the circle with 3 dots at the bottom on your screen. From there, select All Panelists in the drop-down menu so that your question will get sent to the correct location and press Enter. Now, I'm pleased to introduce the moderator of this event, Megan Wolf. Megan is the Senior Policy Development Manager at TIFA, where she works with the policy development team to advance a modernized, accountable public health system. In her role, she oversees the Age-Friendly Public Health System Initiative, which partners with state and local health departments to implement a public health framework to improve the health and well-being of older adults. Welcome, Megan.
Thank you, Margie, and welcome everyone. I'm going to provide a little background and context, and then we'll get right to our great panel of speakers today. Next slide. For those of you who are new to us, TIFA is a public health policy, research, and advocacy organization dedicated to ensuring optimal health and well-being for every community and individual. This project, our Vaccine Access Project, to explore the challenges and solutions to ensure vaccine access for those who are homebound, began barely 2 months ago, but since that time, significant progress has been made. We've seen multiple news reports about vaccine access for those who are homebound. And just this week, the Biden-Harris administration announced an allocation of about $100 million to ensure vaccine availability for aging and disability networks in every U.S. state and territory, and to expand vaccine availability for people with disabilities and older adults. The announcement says specifically that these grants will enable the aging and disability networks to identify people who are unable to independently travel to vaccination sites and to provide technical assistance to local health departments to improve access to vaccines for people with disabilities and older adults. And I will put the link for the announcement, that announcement in the chat in just a few minutes. But this has really been an integrated effort to address this issue and get vaccines to the homebound. This action by the administration is an indication that there is recognition of the importance of this issue and that our government leaders are listening and working to make progress to get these vulnerable populations vaccinated. Next slide. This project is made possible through the generous support of the John A. Hartford Foundation, which is dedicated to improving care for older adults, and the Cambia Health Foundation, which is also dedicated to improving the way people experience health care. We're so appreciative of these funders whose vision is helping to make this initiative possible. Next slide. Homebound older adults are really an overlooked and understudied population. Most live in the community and not in nursing homes or other elder care facilities. They are often very isolated with little emotional and social support except for that of their family caregivers. And while older adults living in elder care facilities have rightly been prioritized for vaccinations, for those we're focusing on today, whether they are older adults or individuals with disabilities, leaving their home to get a COVID vaccine is challenging, if not impossible. Next slide. Now, there's a lot of variation in defining the term homebound and identifying these individuals. In Colorado, I just heard today that they are defining the homebound as those who never or rarely left the home in the past month, regardless of the reason. Now, this matters because of the numbers, but also identifying these people. So the reason I'm showing this slide is to demonstrate the vast difference in the numbers based on how the population is defined. The figure most often referenced in terms of the total number is about 2 million completely or mostly homebound adults. But then if you look at like the AARP definition, it could jump up to 12 to 15 million. So it is a really vast difference, and it's an important differentiation. And I know our panelists today are going to address this as well. Next slide. Those who are homebound often live with functional disabilities, multiple medical comorbidities, depression, and cognitive impairment. This population is vulnerable and at significant risk for decreased quality of life, increased medical complication, loss of independent living, and mortality. And yet, homebound older adult populations have received minimal programmatic attention, even as the number of disabled older adults continues to increase and the demand for home care services continues to grow. Next slide. As TIFA and our consultant Ripple Effect have been studying, researching, interviewing, and listening, we have identified numerous challenges as well as some wonderfully innovative solutions to delivering the vaccine to those who need it at home. And you're going to hear from about some of those today. Unfortunately, there are still challenges, as I mentioned just a moment ago, in identifying who these individuals are and ensuring the capacity for local authorities to put the lists together to identify them. State and local governments have no clear path to ensure they will be able to find all of them, nor how to address the complexities of increasing the numbers of certified vaccinators and accessing and appropriately handling sufficient vaccines for multiple home visits that are geographically dispersed. Vaccinating this population is made even more challenging because of the variation in vaccination policies, reimbursement difficulties, and workforce needs within and across states. And vaccinating caregivers is also an issue that is important, and yet eligibility of caregivers, especially family caregivers, varies across states and jurisdictions. Next slide. The topics in this graphic represent the themes that have emerged in our recommendations research and will help to organize the recommendations that TIFA is developing. We are committed to ensuring that all of the recommendations be implemented with health equity as a lens and with a policy focus. And next slide. So at this time, I'm going to introduce our three speakers, and then after their presentations, I will come back and briefly share the set of recommendations that we are working on, and then after that, we'll open up for discussion, for your questions and comments, as well as those from our speakers. So first today, we'll hear from Dr. Amanda Cohn, who is Chief Medical Officer for the Vaccine Task Force and the National Center for Immunization and Respiratory Diseases at CDC. Dr. Cohn has been tirelessly working to support public health departments with information and guidance on the COVID vaccine. Next, we'll hear from Dr. Tom Cornwell, who is Senior Medical Director at Village Medical at Home and has extensive experience delivering home-based care, which gives him great insight in the delivery of vaccines to those who are homebound. And then finally, we'll hear from Ingrid Ulrey, who's Policy Director at the Seattle King County Public Health Department, where her team has been in the vanguard in developing innovative strategies and policies to ensure vaccine access for those at home. So we can go to the next slide, and I will turn the virtual platform over to Dr. Cohn.
Thank you, Megan, so much for having me here today. I'm going to help set the stage for the discussion and for you all to hear more about the amazing things that are happening and all that needs to be done to ensure homebound and older adults are vaccinated. Next slide. Next slide. So we know that the risk of severe outcomes from COVID-19 increases with age. And although most disabilities are not known to increase the risk of severe disease, approximately 1/3 of people with disabilities have one or more high-risk medical conditions. Many states are vaccinating, most states, if not all, are vaccinating older adults and adults with high-risk medical conditions. However, some older adults and persons with disabilities face a number of challenges getting COVID vaccines. Today, I'm going to provide some background on considerations for COVID vaccination of older adults, including those who are homebound and adults with disabilities. Next slide. Adults 65 years and older are included in phase 1 of COVID-19 vaccine recommendations. The rationale for including older adults in phase 1 vaccination efforts was due to the significant risk and severe outcomes with increasing age. For example, relative to 18 to 29-year-olds, older adults 65 to 74 are 5 times more likely to be hospitalized and 90 times more likely to die. At 85 years and older, they're 13 more times likely to be hospitalized and 630 times more likely to die if hospitalized compared to younger adults. Next slide. Race and ethnicity are also predictors of increased risk of severe outcomes among older adults. Among adults aged 65 and older, the risk of COVID hospitalization is 2 or more times higher among non-Hispanic, American Indian Alaskan Natives, non-Hispanic Black, and Hispanic or Latino populations 65 and older, compared to non-Hispanic Asian or Pacific Islander or white populations 65 and older. So I really appreciate Megan's focus on thinking about addressing the needs of homebound adults through a health equity lens as well. Next slide. Interest in COVID-19 vaccination of older adults is relatively high. The likely acceptance of COVID-19 vaccination increased substantially from December compared to September among older adults. Results of surveys reported in February suggest that 66% of adults age 65 years and older were absolutely or very likely, and 15 were likely to get vaccinated. Only 18.7% reported they were not likely. Next slide. And for the most part, a Kaiser Foundation survey conducted in January found that older adults are optimistic about getting the vaccine. However, many people are also frustrated and confused about how to get information about vaccination in their communities. Next slide. And next slide again. So with that background and setting the stage, we actually have really good news in the overall number of older adults who have been vaccinated. So as of March 28th, 72.4%, or 39, nearly 40 million adults aged 65 years and older had received 1 or more doses of COVID-19 vaccine. This is really a remarkable feat to have vaccinated over 70% of the population, of the older adult population, in such a short period of time. But the concern is that that additional proportion, that additional 28, 27% of adults that need to be vaccinated in that age group, potentially have serious barriers or hesitancy about getting vaccine. Our supply for vaccine is also increasing, which should help increase vaccine availability for older adults. As you all know, by May 1st, we anticipate all adults will have vaccine available in their jurisdictions. So what are the challenges to vaccinating older adults who are homebound? And Megan just described some of these really well. There are challenges in identifying older adults who are homebound. There are problems reaching those individuals and vaccinating them and their paid and unpaid caregivers. Enumerating these groups have been challenging. And then one really important component of success will be to ensure that promising practices across jurisdictions are shared. And so I know we'll be hearing some of those practices today, but there are many others that jurisdictions have implemented that we can learn from. Next slide. In addition to challenges getting vaccination information, disabilities are common among older adults. Challenges related to disabilities increase in age, with the oldest adults reporting high rates of reduced capacity to perform activities of daily living. So, although older adults are, for the most part, very interested in vaccination, many may have difficulty accessing vaccines. Next slide. And as adults age, a higher percentage need assistance with activities of daily living. Next slide. And as Megan just discussed, the definition for homebound persons, a person is considered homebound if they need help of another person or medical equipment, such as crutches, a walker, or a wheelchair, to leave their home or doctor, and believes that their health or illness could get worse if they leave their home. And it is difficult for them to leave their home, and they typically cannot do so. When we began at CDC to think about this population in collaboration with many of our partners, we actually took the largest approach and a more expansive definition than this definition of homebound, and included many adults who are semi-homebound. For example, may leave the house up to twice a week, but still potentially would have significant barriers to getting vaccinated, for example, in a mass vaccination clinic or in other vaccination locations. We recently posted new guidance for vaccination of homebound persons for healthcare providers who vaccinate persons who are homebound. And this clinical guidance helps address some of the technical logistical barriers of actually bringing vaccine into the home efficiently and effectively while maintaining the integrity of the doses. Next slide. Information on COVID vaccination for older adults and people with disabilities needs to consider additional challenges such as access to the computer or internet. Messaging needs to include formats that do not rely on websites and social media, for example, newspapers, radio, and TV. And planning should consider collaboration with partners that may be able to help disseminate written information. Communications should also meet the necessary requirements of the ADA and other disability rights laws. Next slide. Providing written materials and other ways to get vaccination information to older adults is particularly important to those without computer or internet access. Although 89% of people overall have internet access, only 76% of adults 65 years of age and older have internet access, and that falls to 55% among those 85 years and older. Next slide. New materials for vaccination of older adults and people with disabilities, including vaccination of homebound persons, are on the CDC website. In addition, a fact sheet for older adults that can be printed into one page and has space for organizations assisting with vaccinations to provide their local organization's contact information is in development and based on the language that is in the third bullet here. Additionally, we have materials that are coming out that are in multiple additional languages, a reduced reading level, as well as sign language videos and other resources for persons hard of hearing. Next slide. And this is just a final list of additional materials that we have available on our website and on other websites. As Megan mentioned, I believe it was Megan mentioned previously, the funding that ACL is able to provide, which they will be providing in the next week or couple of weeks to programs that can help with transportation services, with getting homebound adults and semi-homebound adults appointments for vaccine and to vaccination sites and make sure they understand the process, will be a really important resource that we hope will help support efforts to get that additional piece of older adults who haven't been vaccinated, vaccinated, and paying special attention to adults with disabilities and adults who are either homebound or have limited ability to leave their home to get vaccinated. Next slide. So in conclusion, the risk of severe disease from COVID-19 increases with age, and older adults should get vaccinated at this time. Older adults are, for the most part, very interested in getting vaccinated. However, many of them have challenges to accessing these vaccines. New guidance is available to aid in vaccination of persons who are homebound, and efforts will be needed to identify persons who need assistance with learning about COVID vaccines, scheduling appointments, accessing transportation to vaccine locations, and arranging for vaccine by mobile vaccine providers. Next slide. And that concludes my presentation. Thank you.
Thank you so much, Amanda. Really appreciate the information, especially the kind of most up-to-date information that you have. It's really helpful. And we're so appreciative of all the work that you and your team are doing. It's just an invaluable, you're an invaluable resource and are really appreciated. Thank you. So next up, Dr. Tom Cornwell. And thank you, Tom, for being with us today. And I will turn the platform over to you. You're speaking, you're still muted.
Sorry, I didn't want to have an echo. And so I too thank you for being a part of this wonderful panel. Next slide. And I want to echo Megan's comments. The CDC just has invaluable information that is just extremely well written, easy to read in terms of both for patients as well as for providers. And as she listed resources, I'm also the executive chairman of the Home Centered Care Institute, which is a nonprofit to support home-based primary care that also has tremendous resources on providing vaccines in the home. Next slide. So I want to kind of personalize this a little more and kind of bring the Homebound into our conversation here in a very personal way. And I'm going to talk a little bit about the forces behind the return of the house call. And you can see them listed here. You know, the aging of our society, we know about increased home and community-based payments, technology, the value of house calls, and then finally payment reform. Next slide. And I want to start with a health affairs article that was published in 2015 by Drs. Christine Ritchie and Bruce Leff, who are very involved in home-based care. It was a quality article, but what I liked about it was the title, The Invisible Homebound, because I'm just so appreciative of Trust for America's Health, and again, the John A. Hartford Foundation, Cambia, the CDC, who are really helping to make the invisible homebound visible. And I think, Megan, when you started with this great announcement from President Biden, you know, we are making this invisible population visible. And one of the invisible homebound was Elsa here. You know, she was born in Germany in 1921 and came to the US after World War II. Before my first visit, she had been hospitalized, which is not uncommon, 6 times in 4 months for multiple medical problems, including her heart failure. She had diabetes. You can see from her right foot and left leg amputation, she has peripheral vascular disease. And she also had pressure sores on her bottom because she literally lived and slept in this chair 24 hours a day. Because of her repeated hospitalizations, the hospital actually told her she had no choice. She had to go to a nursing home because in their view, she was clearly not able to care for herself. When I first met her at this time, she shared that part of the reason why she lost her legs was because of frostbite damage caused by cold winters in a prison camp in Germany during World War II. And she said that she had been forced into a prison camp early in life, and she just didn't want to be forced into a nursing home at the end of life. And what mattered most to her was staying at home. And so instead of sending her to a nursing home, which hasn't been my job, we quickly, with home-based primary care, got her heart failure and diabetes under control. We got home health out that she wasn't able to have earlier because there was no provider to sign for it. And we got her a hospital bed, her pressure sores healed next. And we actually got her so much better. Next slide. That we were able to pay for transportation to get her to an outpatient rehab center to get new prostheses so she could actually walk again and actually get into the bathroom. I didn't realize at this point she hadn't been able to get into her bathroom because the wheelchair didn't fit through the doorway. And so just so amazingly helped her life, but also dramatically reduced costs. And you can see bringing primary care, which includes immunizations, to these patients just so remarkably helps their care as well as reduces costs. Next. And this is just a slide of those costs. The homebound population that again has been pretty invisible is part generally of this 5% of the healthcare population that consumes 50% of all the costs, and the top 1% that just unbelievably consumes 20% of all the costs at over $110,000 per patient. And we need to provide these patients primary care so they don't have to use acute care and drive up these costs, which is also not good for their health. And again, immunizations is a part of that. Next. And then another force, and I think this gets into the public policy that we're talking about, here is a great example of how public policy can so dramatically impact the population we're talking about. Long-term support and services are made up of institutional care and home and community-based services. Back in the 1980s, 1983 specifically, 99% of all funding went to nursing home care. And over time, because of policy changes, there's been more support in home and community-based services. So now over half of long-term support and services goes to supporting nursing home eligible patients to remain in the community. but these patients also need to get care in the community, along with, as we're talking today, the immunizations they need when they are nursing home eligible and cannot get to mass vaccinations. And this is, again, just an example of how public policy can benefit the homebound and support what matters most to them, which is oftentimes staying in their homes. Next. And I did want to add that house calls are mainly high-touch primary care, but we do have the high-tech capability to really do the highest quality of care in the home. You can see here my smartphone in seconds can get an EKG. An ultrasound now fits into the palm of your hand, and you can use your smartphone as the screen. X-rays can be done same day. They're all electronic, and so you can get the report the same day. We can draw any lab we need in the home and spin it down in the centrifuge that plugs into the cigarette lighter in your car. There's also therapeutic technology such as home renal dialysis, hemodialysis, as well as smart pumps that can do IV antibiotics and IV fluids in the home. So I can actually do more technology in the home than the great majority of primary care offices can do. And so it was really technology that drove care out of the home in the last century into the office, because you had to go to the office or the hospital to get that technology. Well, now we can, because of the technology has become portable, we can bring it to patients in their home. Next. And so the last part before I get to the COVID vaccine specifically is I just want to show you some data. You know, I showed you a wonderful anecdotal story, but we also have some good data as to the value of this. And the first major data came from the Veterans Administration's, the largest home-based primary care program in the country. And it came because in the middle of the last decade, Dr. Tom Eads, who runs geriatrics in the home-based primary care program for the VA, was told he had to cut the program because, as you can see here, they were spending $11,000 more on care in the home by sending doctors and nurse practitioners and physician assistants and mental health workers. And he was told that they just could not afford this. Well, he asked if he could have all the cost data analyzed, and he was given approval, and it was sent to University of Pennsylvania. And I think what they found even surprised Dr. Eads. Next, they found an 87% reduction in nursing home costs for the VA, a 63% reduction in hospital costs, an overall $9,000 savings per vet. And when you multiplied that by the 11,000 vets in the program, they were actually saving $103 million. And so not only was the program not cut, but it's now up to 38,000 vets in this program in all 50 states. This data was first presented on the Senate section of the Capitol Visitor Center and really brought home-based primary care to the attention of both CMS as well as Capitol Hill. Next. And the last thing I want to talk about, and unfortunately this is a significant aspect, as we know, of COVID, is the costliest year of life, not surprisingly, is the last year of life. It consumes 25% of Medicare dollars. And you can see from the bar graph, while 70 to 80% of Americans say they would like to pass away at home, this has actually increased some to 30%. Hospital deaths have been 30%. This was in 2017, and the nursing home about 20%. The reason why it's so costly is 65% of Americans are in the hospital in the last 90 days of life, and 29% are actually in the ICU in the last 30 days. And if you know the data, the ICU is not the place you want to be if you are looking for a peaceful death. And so next slide. And our numbers, so this is the practice that I was with for 23 years on Northwestern Medicine's home care physicians. And since 2003, the bar graph, you can see our numbers, where 75% of our patients, about 20 to 25% of our patients die a year. We're dealing with very, very sick people. And but 75% have passed away at home. And you can see our hospital numbers just so remarkably less, 37% being in the hospital. So over half of our patients are not even hospitalized in the last year of life, and only 5% being in the ICU. Next. And so to the topic on hand, and again, I really appreciate how the John A. Hartford Foundation, Trust for America's Health, Cambia, CDC are all just getting these patients really on the radar. And we have just had some wonderful publicity. This is just all in the last month, where the upper left is Dr. Liz Davis given a COVID vaccine in inner city Chicago. The New York Times article was on Long Island. It is Dr. Abrashkin, and you can see her carrying and we're going to get into this a little bit, the cooler, because you have to maintain the cold chain. Dr. Cohn referenced, making sure we keep the stability of these vaccines. And so we're giving them quality vaccines in the home. And then the last picture here on ABC News, as Ingrid is going to talk about the different providers that are doing this. This is a public health nurse, Robin Tanner, with the Northern Navajo Medical Center, giving a homebound patient a COVID vaccine in New Mexico. And so COVID has really even added to bringing the visibility of the importance of home care, whether it be home health, hospice, public health, home-based primary care into the home. Next. And so I'm going to end with just some of the logistics in terms of doing vaccines in the home. Obviously there are great efficiencies with doing mass vaccinations versus at home, but Dr. Cohn described that, there is this population that we're talking about today that literally it is impossible unless you want them to go by an ambulance to a mass vaccination to get them there. And so who are doing this? And again, you're going to hear this more from Ingrid, but it's home-based primary care, home health. And it's very difficult for home health because one of the things we're going to talk about in terms of policy is up to 2 weeks ago, the payment for administering the immunization was $16. And so for the travel time, the observation time, it was really a labor of love if they did this. There was no way that they could possibly cover their costs. CMS just 2 weeks ago increased that payment from $16 to $40, which again is greatly appreciated, but still just does not cover the costs to do 1 or 2 immunizations at a time in the home. And then there's the public health nurses you heard about, the pharmacists that are doing a great job of giving vaccines, but again, you have to get to them, as well as paramedics that you're going to hear about from Ingrid. And so the cold chain, I think we'll go down to the table at the bottom that kind of shows some of the difficulties in terms of logistics and some of the advantages, particularly to the J&J Janssen vaccine. One of the things that we have heard about in terms of the is getting people, vaccine hesitancy is one of the areas that Megan talked about that we have to kind of combat. And one of the problems is when the J&J vaccine came out, it showed 72% efficacy at preventing COVID, but it is actually 86%. It is a very effective vaccine at preventing severe disease. But even that is, people, thinking, oh, the ones that are 95 and 94 are obviously better, but there's been no head-to-head comparisons. And so you really cannot say one is better than the other at this time. And so there's a huge advantage to J&J because of the travel time and the observation time when you're only dealing with one vaccine at a time, or maybe 2 or 3 if you're talking about caregivers. But the one vaccine gives the J&J just a huge logistic advantage. Another thing that most people don't know about is that there's only 5 doses in the J&J vaccine compared to 10 in the Moderna and the Pfizer, because you only have 6 hours once you first puncture it. And so it's very difficult to get to 10 homes. One of the things that we did find out, I'll give Steve Landers credit for this, one of the home-based leaders in this country, where he actually contacted Pfizer and Moderna and did find out that if you do pre-draw these vaccines, that they have the same stability in a filled syringe, the 6 hours, as if you have them in the vial. That was very important for us. So some of the practices are meeting in the morning and dividing the Pfizer or the Moderna doses so that they can get the doses in that 6-hour period. And then the last column I'll talk about is after puncture. You can see one of the advantages of the Pfizer and the Moderna is they can actually be kept at room temperature up to 77 degrees for up to 6 hours, where the J&J is only stable for 2 hours at room temperature. And so to keep it, to give you that 6 hours to provide all 5 doses, to different homes. You just need to keep it in a cooler, and people need to have these data logger thermometers that assure that you keep it within that temperature during that 6-hour time for that stability that Dr. Cohen talked about. And so you do need to do 15 minutes of observation on everyone if they have had severe reactions to vaccines in the home, or severe reactions to vaccines in the past, or if they have had severe allergic reactions. You're supposed to wait a half hour. And in mass vaccinations, I was on the call with the public health department yesterday, and we're going to get 600 J&J vaccines for a homebound practice, which I'm very excited about. But they say in their mass vaccinations, they have 3 nurses that are observing up to 40 patients at a time. And again, you're getting paid the same in these mass vaccinations. And so the logistics for doing it in the home are just more difficult from a payment standpoint. But since these providers are going into the home anyways, we actually, at the practice at Northwestern I was with for 23 years, we consistently had the highest percentage of patients getting the flu and pneumonia vaccine. So we were actually the best primary care practice because we so knew the importance of it for our patients. So it is very doable. You just need to kind of go through some of these hoops in terms of making sure that they are getting stable vaccine in the home. And that is my time, Megan.
Great. Thank you so much, Tom. That was so helpful and so informative. You obviously have a great passion for the work that you do as well, and we appreciate all that you're doing to take care of the patients that are in the home, to make sure that they can age in place and healthfully. So thank you so much. And now we'll turn to Ingrid Ulrey from Seattle King County. Ingrid, the platform is yours.
Great. Thank you, Megan. I'm just so grateful to you and to the whole team at TIFA and the other partners for this focus on homebound vaccination. I think, just really simply put, if we don't bring vaccines to people who can't leave their homes, they will be left out, and they will remain at very high risk of serious illness and death due to COVID-19. So this work is really important. It's also really challenging, and we need to learn from each other about how best to go about it. So thank you for the forum. Thank you also for TIFA's work in pioneering this notion of age-friendly public health. This is very meaningful to me as someone who spent the bulk of my career in the aging sector, both with SEIU representing the interests of the long-term care workforce, and then nearly a decade as the advocacy director for AARP here for the state of Washington. So coming from where my own experience, my reflection is that nothing more than the pandemic could have made it more obvious why it's critical that public health and the aging network align and ally. And that's not only to fight back against this communicable disease of COVID, but also to address broader health threats such as social isolation and loneliness that have been so exacerbated by COVID. In King County, our close partnership with our Area Agency on Aging and other aging and disability partners, which were formed pre-pandemic, have really been instrumental in our ability to quickly stand up an effective COVID response. So I'm going to spend the next few minutes describing how we are working together to address the challenges, all these logistical challenges you've heard about from the previous speakers, and get shots in arms to people who are homebound. And then I'm happy to take questions. So next slide. And next slide. Thank you. So just a quick overview. In King County, we have a coordinating group, which I've been helping to staff and support, of people from public health, from our AAA, as I just mentioned, city officials, people who work for the housing authorities, the long-term care providers, and other advocacy groups. We've been meeting multiple times a week throughout the pandemic, earlier focusing a lot on COVID testing in long-term care facilities and across older adult population, and more recently on vaccine delivery. And our group, frankly, struggled for several months on how to solve this challenge of vaccinating the homebound population and surpass all the logistical challenges that have been discussed. Finally, we landed on a strategy which I think is pretty straightforward, which I'm just giving you a quick overview of that strategy on this slide. And there are really just 5 major elements to it. First is just defining what we mean by homebound for the purposes of eligibility of in-home vaccination. The second is working with community partners to generate demand, or in other words, developing a list of who the focus population group is for this service and making sure people in the community also know about the service. The third is identifying vaccinators and piloting a delivery protocol. The fourth is developing the systems and capacity to screen, appoint, dispatch, report, and operationally get the work done. And then finally, but very importantly, is more of the sustainability, is working with providers to ensure ongoing capacity for routine immunization. Next slide. I think what I've described is actually pretty straightforward and also replicable and potentially even more easily in smaller regions or communities than King County. We're not a small community. King County is a large area. Our local health jurisdiction is actually the 9th largest health department in the country, bigger than many state health departments. The quick facts I put for you on this slide is we have a total population of 2.2 million people. Our goal is to equitably, efficiently, and quickly vaccinate a minimum of 70% of all eligible adults and children when they become eligible. And progress to date is just this week, earlier this week, we surpassed the 1 million mark for shots in arms. So we're making progress, but we have a long way to go. Next slide. I want to underscore the strong commitment to equity in King County as it relates to our vaccine delivery operation, really under the leadership of our county executive, Dow Constantine, our Mayor Jenny Durkin of Seattle and other city mayors, as well as our health director, Patty Hayes, and our health officer, Dr. Jeff Duchin. With their leadership, we developed principles for equitable vaccine delivery, which we ask all providers to understand and abide by. And these principles emphasize removing barriers to access and serving disadvantaged populations and those at highest risk first. But like other areas of the county, or the country, sorry, we've been struggling and working intentionally to close the gaps that we do see in vaccination based on race and ethnicity. Dr. Cohn from CDC mentioned earlier, one of the metrics we're all watching around the country is the first go group for eligibility, people age 65 plus, what % have been vaccinated. So we're a bit ahead of the curve in King County overall. More than 80% of people age 65 plus in King County have received at least their first dose. So we're happy and excited and proud of that. But we are concerned about these remaining gaps based on race and ethnicity and are working to close them. So you can see from this chart that while it's 83, almost 84% for the white population 65 plus, it's significantly lower, especially for Hispanic and Black or African American. Since I put this slide together yesterday, we bumped up from 69 to 70% of all Black and African American older adults in our county vaccinated. So that's a relief. Again, our minimum is everyone across all race and ethnicities and geography above 70%. That's what we're shooting for. So it's really, this focus on equity is the ethical basis for our sense of urgency in reaching the homebound, who really qualify as one of the very hardest to reach populations, who have the biggest barrier to really accessing any vaccine in any of our other modalities. So next slide. We take the approach in King County that no single vaccine mechanism will be sufficient to ensure optimal vaccine uptake, and that it's really essential to sort of meet people where they are and provide vaccine across multiple modalities. So I'm not going to go through this whole table, but you can see the range. In addition to the mass sites which were talked about earlier, we have more than a handful of those in King County. They're delivering thousands of doses per day. We also have many people accessing vaccine through their health system, their community health center. We have a systematic way to set up pop-up or community vaccination events in trusted locations. People are also increasingly accessing vaccine at pharmacies. And notably for this conversation, we have mobile teams who we are dispatching to serve people in adult family homes, in low-income senior housing, and now soon as they become eligible, the homeless population in homeless shelters. At the very bottom of the list that I've underlined in red is this modality of in-home vaccination. This is reserved for the people who meet the definition, which I'll share in a minute. And notably, it says in the chart low output capacity. It's really ultra low. It's the lowest throughput, slowest, most labor-intensive way that we can get people vaccinated. We are finding that our teams of 2 can visit between 5 and 7 sites or homes per day, generating 10 to 15 doses per day as they also vaccinate caregivers. Each of these modalities has their own value. So in-home vaccination is not about volume. It's really about serving the hardest to reach population from an equity lens. Next slide. We struggled with how to define homebound for the purposes of eligibility for in-home vaccination. We landed on the definition I've illustrated on this slide, which is adults age 16 and above. Currently it's 50 and above, but that's changing very quickly, so I'm putting in 16 for now. Who have not been vaccinated, who have an injury, developmental disability, or medical condition that makes it difficult to leave the home, and for whom it would require considerable and taxing effort to access vaccine outside the home. That is our working definition. We really are striving to find a balance between having it focused enough so that we're ruling out individuals who could otherwise access vaccine through other doors. Because, as I said, for the goals of doing this efficiently and quickly, in-home vaccination isn't the answer to that. So if we can get people to other doors, we want them to go through other doors. So that's why it's focused, but also expansive enough so that people aren't left out. And next slide. This has been another challenging part of developing the in-home vaccination strategy, is just getting our arms around the focus population, generating demand by developing lists of individuals for whom this will be a necessary and important service. We're doing this in phases. So phase 1 is we generated a list, which is shy of 1,000, but moving towards there. That was really from our close-in partners. So our aging network identifying home care clients who meet certain criteria that would indicate they would meet the definition. Also providers of Meals on Wheels and what we call the Chicken Soup Brigade, a similar service in King County, as well as the Alzheimer's Association, identifying lists of people with dementia and their caregivers who meet the definition, as well as fire departments who have frequent callers who are homebound. And finally, also people who just called into the health department requesting this service. That is our go first strategy of developing that list and serving those individuals. Our next phase will we be curating lists of additional potential individuals, both from primary care organizations, from managed care organization referrals, as well as we've received a very large list of names from our state agency partners, and we will be culling through there to deduplicate the list and understand who within it is eligible. And finally, we haven't yet, but we will reach a point where we publicize this service to the community by posting it on our public health website, cross-posting with partners, and generally making a public announcement. We are waiting at this point until we are more fully, have our systems more fully tested more doses flowing into our county and more capacity in place, but we're getting there very soon. And the next slide. Identifying vaccinators was also not easy. We started first with the in-home care providers or primary care home health agencies, hospice agencies, for many of the reasons that Dr. Cornwell described. They were not ready and prepared to vaccinate. So we moved on to other options, including volunteer groups, medical, public health reserve corps, academic UW volunteers. That we hit a number of walls of challenges that wasn't going to work. So here's where we landed. Our number one vaccinator group for homebound teams are all fire departments, EMS. We have 3 major departments around the county who are committed to this work. They were already set up and running with mobile teams that I described earlier, serving adult family homes and senior housing. So this work is really an extension for them of that work. They reduced the team to 2. Sometimes they would just spend the day visiting 5 to 7 homes. In other situations, they would identify people who are homebound and maybe serve them at the end of the day or between visits with larger sites. So we're very appreciative of our fire department partners. Secondly, is our own in-house public health mobile teams. We have limited capacity. They have also been serving in the low-income senior housing and will be serving in homeless shelters soon. But currently, they have taken some geography within the county, and we're using our own public health nurse and teams to serve individuals who are homebound. We are also currently in the mix of contracting with a pharmacy to cover another portion of our county for which we didn't have a fire department or mobile team assigned. And finally, we have discussions with the major health systems and found that one of the major health systems has a large volume of their own established patients who are designated homebound, and they will be serving them themselves. So it's complicated, and it hasn't been only just one approach. It's a variety of vaccinators that we've identified. Next slide. So this is the 4th element is really just operationalizing the whole program. A big part, well, this was more challenging in the pre-COVID relief package world, is feeling more feasible now because it takes resources. Again, super appreciative of our partnership with the Area Agency on Aging and others to share the load. A big part of this is screening, is contacting individuals referred to us as potentially eligible, asking them a series of questions to ensure that they meet the definition, they want to be vaccinated, they verbally consent, and then arranging for them to be appointed. Because of the digital divide that Dr. Cohn spoke of yesterday, this is all phone-based work. So we have patched together 3 existing call centers, one through public health, one through the customer service for our county, one through the city of Seattle, to handle the load of doing this screening. So the screening and the appointing is labor intensive and phone-based. And then through public health is where we're really organizing the dispatching across geographies of the different teams and the reporting and tracking of how many visits have been completed, how many people yet to be served. Next slide. I think the final element is what we're thinking more about now that we've piloted and just barely started to launch. And really the thing that's made the launch possible, again, is the arrival of the Janssen or Johnson & Johnson 1-dose vaccine in King County. Now that we've got going, we're thinking about how does this, what's going to sustain this for the long haul? We all know that COVID is not going to go away, that this will continue to be a chronic challenge for society and particularly for older adults. So we are asking questions like, after the emergency response, how will COVID vaccination for homebound be built into routine care? Who are the largest in-home care providers in our county? We've started having conversations with them. Some of the hurdles that have been mentioned have been proved, including reimbursement rates. So what is their readiness to go forward, to have access to doses, the structures and reimbursement systems in place. So because what we know is this system of doing the first round of mass vaccination through fire departments and public health teams and patching it together is not what will work for the long haul. So how do we build that muscle into the system so this population will continue to be served? Next slide. That kind of covers the 5 sort of major elements of how we're going about this in King. I just want to punch out again some of the major lessons that we've learned implementing this locally. The first is that it's important to make vaccine sites in the community as accessible as possible, and also to intentionally give people the option of transportation. Doing these things will reduce the need for in-home vaccination. Which again is not the preferred modality for people who can go through another door, will be able to serve everyone more quickly and efficiently. The second is, and Dr. Cornwall, you definitely emphasized this as well, is before the arrival of the Janssen J&J vaccine, this felt very undoable to visit, such a low throughput, high intensity intervention, and then to have to go back and have a second visit feels like a very large hurdle. So really the 1-dose vaccine makes this feasible and within reach. The third is operational flexibility in ensuring that when we send a team into a home, they vaccinate not only the individual who is homebound, but also their caregiver or other eligible members of that household. It makes a lot of sense, both for efficiency and just to ensure that we're getting as many shots in arms to as many people as possible, and recognizing that caregivers face their own hurdle of challenges and difficulty in getting time out from their caregiving to go get vaccinated. Finally is just recruiting vaccinators with pre-pandemic understanding of and relationship with the homebound population. That is one of the beauties of working with the fire department partners. They know a lot of these individuals in their local communities and have sometimes received calls from those homes before, and they also know their communities. So that has worked out beautifully, even though we know that the fire departments are not the long-term solution for sustainability. And finally, I can't emphasize enough how critical having, before the pandemic, having already set up our partnership with the Area Agency on Aging and the trust that we built between public health and the aging sector. And one thing that I did early on in this was actually just recruit and hire the former director of our local AAA to work directly embedded in our response. And she's been an incredible leader in this effort. So those are the major lessons. I have just 2 more things I want to share. So next slide. Yep, thank you. Just to put sort of a human point on this, and I appreciate Dr. Cornwall how you did this as well. I'm just going to read this quick testimonial. So it's, my mother is 96. She lives with advanced dementia and accompanying physical decline. She lives at home with round-the-clock care. I manage her care and visit daily. She has not left the house in 2 years. Our caregivers, alarmed by anti-vaccine propaganda, have declined to get COVID vaccines. My sister, a COVID-19 denier and anti-vaxxer, nonetheless visits regularly. Needless to say, I'm frantic to get my mom vaccinated. Her healthcare provider says the only way my mother can be vaccinated is to come to the hospital and wait in line. Her advanced dementia and associated physical decline prevent this. Are you aware of any resources available to help fragile homebound elders like my mom to obtain COVID vaccine? Next slide. I think the answer to that question that we all want to say is yes, yes, we can do this, which reminds me of this tagline that we're seeing around Seattle right now. It's actually, "We got this, Seattle," but I'm going to broaden it to King County. And it's something that every time I see this message really resonates for me, because while it's been a brutal year, it's been hard, we really all are in this together. And more so really than any other aspect of the vaccine delivery work we're doing, I'm struck about how this focus on homebound really gets to the center of that sense of community connectedness by sending the clear message that you know, people who are struggling with COVID in private, behind closed doors, you can't get out, but you are not invisible. We're going to send someone to you because you belong here and you matter. So we got this, King County. Thank you.
Wow, Ingrid, thank you so much. That was really powerful. Very powerful way to end. Very emotional. And we are in this together. And I appreciate all of you, Amanda, Tom, and Ingrid, for your dedication to this issue and to the humane aspect of this issue as well, to make sure that, you know, these people should not be invisible. So really appreciate that. So if we could go to the next slide, please. And I just want to talk briefly about our recommendation. So again, with support from our funders at the Johnny Hartford Foundation and Cambia Health Foundation, TIFA has led 2 national convenings. We've conducted multiple interviews, reviewed countless articles and other literature, and we're facilitating biweekly huddle calls to identify the high-level policy solutions. So what you see on this slide are the results of that work, which are being fully fleshed out for a policy brief to be published in about a month. Excuse me one second, really pulled on my heartstrings. We will be, the policy brief will be taking each one of these recommendations and building them out and providing examples for many of them. And these recommendations are ones we think federal, state, territorial, local, and tribal governments should adopt and implement, including, obviously, prioritizing the homebound and their caregivers, providing a definition so that you know, other jurisdictions can optimize the definition for their own jurisdictions, identifying possible data sources as they've done in King County, and initiate data sharing agreements. So if there's a problem with, you know, from one stakeholder to another, how can that data be shared? Engaging trusted community partners, ensuring that all the costs, the full costs, are fully covered, ensuring equitable access to the vaccine, wanting to make sure that those vaccinators reflect their community in terms of developing that trust, providing flexibility and creativity in innovative solutions, and then making registration and scheduling easy. So those are the overarching, very succinct way of describing the recommendations that we're working on. Again, that policy brief is being drafted and reviewed as we speak here, and will be published hopefully in about a month. So we can go to the next slide, and I know that we have a number of very, very good and potentially challenging questions for our panelists. We'll be sharing those in just a moment, but for those of you who may have joined late, to submit a question at the bottom of your screen, you can look at the circle with the ellipses in it. You can either use that function or the Q&A button in that panel. Type your question in the Q&A box, select all panelists, and then just hit enter. So it's a very easy process. Again, we have had lots of questions come in both through the chat and the Q&A. So we'll go to the next slide so we can just see the pictures of our presenters. And then Karan, if you would unmute yourself, please, and provide the first question.
That's great. So the first question is, with the definition being quote unquote rarely left the home in the past month, how do you separate the truly homebound from those choosing to stay home due to the pandemic?
So, and I think that question may have been driven by my comment about the definition. That I think that definition came from Colorado, but I just, you know, I offer to the panelists just kind of a broader question about different nuances in the definitions, you know, and how can different jurisdictions, you know, deal with the different nuances.
This is Amanda. I think I can just address part of that,
So,
without diminishing, while still needing to address the critical barriers and needs of truly homebound, from our perspective, um, uh, you know, uh, considering sort of a broad definition of individuals who need to get vaccinated, who have been in the home, regardless of whether or not they're trying to protect themselves or whether or not they're truly their limited activities of daily living limits them from leaving the home. We want to make sure that all of those individuals have the ability to get vaccinated. I certainly think that truly homebound individuals that require nursing care and other types of home support and have agencies supporting those individuals, we are able to identify and list a little bit better, even though there are still challenges. But I'm not sure from a, I'm not sure from an implementation perspective, the goal would be to reach all of those adults.
So, oh, go ahead, Tom. Sorry.
I was going to say, Ingrid, you actually put it well. I think this is, in medicine, we call it, sensitivity and specificity. Where do you want to err? Do you want to not miss anyone, or do you want to be more specific to make sure that you target resources to the ones that really do have difficulty getting out? Medicare does have a definition, and that's actually, I saw part of the definition in your definition, Ingrid, the taxing effort to leave the home. And even in the Medicare regs, they say you can go to a beauty parlor once a week or church once a week and still be considered homebound. And so that is the reason why in Megan's numbers at 2 million to 12 million. So I typically use 4 million because, and there's a reason behind that, but it really does depend on, what your goal is in terms of not missing anyone, or making sure the resources that you use are targeted to people that otherwise would have no option to get out of the house.
Yeah, very, very important distinctions. Ingrid, I wonder if you could address as well what led to the way that you ultimately that King County has defined homebound.
Well, thanks, Megan. So yeah, we were just trying to strike a balance between focused enough. So if people can use another modality, they would, but expansive enough so no one gets left out. So keeping it pretty general and saying, if it's assuming that you have conditions and make it difficult to leave the home, and then this is unique to vaccination, and saying, and for whom it would require considerable and taxing effort to access vaccine outside the home. One thing I wanted to mention is that it's really important to have access to drive-through sites. For some individuals with health conditions, a drive-through site is much more feasible. So as much as we can enable people to access other modalities, all the better for meeting the goal of completing this quickly and efficiently. So finding a balance.
Yeah, I think that's really important as well. Thank you all very much. Karan, next question.
I'm going to go with a quick question because it's come up twice. This is for you, Ingrid. Can you share the questionnaire that is used, the phone screening tool? Are you able to share that with participants?
Yes, we can share that post webinar, however that's feasible. Megan, I don't have it right in front of me,
Sure.
but we've been working on refining that so to keep it as brief as possible, but just to check the right boxes and cover the necessary pre-questioning so that we can make sure that we're not sending a team out to a home for someone who has not consented or has issues that would not make it feasible. So happy to share, and I can share through TIFA with Megan through TIFA after the webinar.
That's great, and we'll definitely make sure that that goes out in the email with the recording and slides. Thanks, Ingrid. Karan, next question.
As a family caregiver of an elderly parent, how can we feel comfortable even after they are vaccinated that they are safe from not contracting COVID? Essentially, when do we decide that taking a parent out is better than being concerned that they can still contract COVID?
So Amanda, I think that CDC might have some guidance on that. Can you pipe in on this question?
Sure. So a fully vaccinated person, so 2 weeks after an individual is fully vaccinated, CDC now has guidance allowing people who are fully vaccinated to see other people who are fully vaccinated and even be around people in small groups and still in sort of your, close-knit family and close friends who have not been vaccinated, as long as those individuals are not at high risk. In translation, I have told, I now let my elderly parents, now I bring my family to have dinner at their house, for example. We will soon have data, we will soon have guidance that even expands those a little bit and says that, it's okay to go to the beauty parlor, it's okay to go to an indoor restaurant. We still don't want people going in high volume or high traffic places. And of course, we always want people to wear a mask and socially distance as much as possible. But we have increasing evidence to support vaccination does prevent infection incredibly well. But at the same time, we also know that the importance of getting older adults, especially, back to see their loved ones and back into their regular routine, and the ability to get out is really important. And so with that, we are moving towards allowing or giving confidence, giving people confidence that their loved ones can start to return to some normal activities.
Great, thank you. Yeah, I think it's a matter of risk assessment, and I think that things are getting definitely much more optimistic, that there is a little bit less risk in going out if you've been vaccinated. So I think that's helpful. Do other panelists want to respond to that question?
Yeah, with a comment and a question. So, I still recommend for my vaccinated seniors to still wear their mask and be careful. And part of that, and I'll be interested from Dr. Cohn if she has data on this, is, for instance, for the flu vaccine, we give what's called a high dose flu vaccine for people over age 65 because they tend not to respond as well to immunizations because their immune systems are just not as good. And are we seeing data at all, Dr. Cohn, that seniors don't have as much of a robust response, or has it been just as strong as younger?
So at this time, we actually don't have evidence like we do for flu vaccine that says that there's a substantially different robust response. The clinical effectiveness is still really high for older adults and for all age groups. I think that in part, the mRNA vaccines are so effective that the immunogenicity and the antibody response is so high that even if their antibody response isn't as high, it's still clinically very effective. That being said, duration of protection will be really important to follow in older adults because that's where we may really start to see differences. I still recommend older adults and everyone continue to wear masks and socially distance as much as possible. Simply because we know that the more we can keep transmission as limited as possible, the further we'll get as the communities are vaccinated in fighting off, emerging variants and things like that.
Thank you.
Great. Thank you both. Karan, next question, please.
So this is going to be a combination of several questions. It's addressing the contact in the home. So how do you go around the issues of informed consent, and how do you approach someone and if they may be nervous opening the door? And how do you determine if a caregiver should be vaccinated? So these are all interactions once you reach the home. How do you determine if a caregiver should receive vaccination? How do you provide informed consent, and how do you engage with the older adult if they're afraid to open their door?
Great, thank you. Any of our panelists?
I'll just say really briefly, we do a verbal consent when we do the screening phone call to arrange for in-home vaccination. For caregivers, we are, as much as possible, serve more than just the single person in the home. In Washington State, I think not different than many other states, our prioritization scheme set by our State Department included unpaid family caregivers in phase 1A. So we haven't, and also included people 50 plus who live in intergenerational households and who require support from a family caregiver. So we haven't had any issue. We haven't had to be too concerned about eligibility for the other people in the home have generally been eligible. So I think 25% of our visits so far were vaccinating not a single person, but also a caregiver or family member along with the individual. And I think that covered your questions. Thank you.
Thanks, Ingrid.
Yeah, and I saw one of the questions had to do with what if you don't have a guardianship or a POA? And every state has what is called a surrogate decision maker law. So just Google the surrogate decision maker law. You know, most of them are pretty consistent in terms of, you know, if you're a spouse, you can make decisions. If your loved one cannot, if you're a child, they do not generally say like oldest child or anything like that. And so the only time that's a problem, and even in, I was thinking this, Ingrid, in the quote that you gave, the only problem is, you know, in her patient, there was an anti-vaxxer with a daughter that was desperate for getting the vaccination, and that can cause some problems if when they have equal surrogate decision-making ability according to the state, what if there's different opinions? But so that was just the last thing in terms of look up your surrogate decision maker law, because the states do, you know, make that relatively clear who makes decisions if a person cannot.
Thank you both. And I think part of that question also was in terms of, you know, someone who comes to the door of a person who's homebound and they potentially don't know them or don't remember who that person is, even if they've seen them before. How do you, first of all, how important is it that that the person who comes to the door is familiar or a trusted party, or shares a culture or ethnicity or race or language? Are those issues really important, and how do you overcome that?
We haven't had any major challenge with that to date, but again, we're just getting off the ground with this strategy. We have had concern about people in uniform as seeming intimidating, particularly to immigrant populations who come from countries where the military may not be a trusted entity. But however, our fire department teams do wear a firefighter uniform, and we have not thus far had any problem with people being concerned about them presenting at the door. And again, it's prearranged, so people know that the team is coming. But as you point out, Megan, people do have dementia and memory loss, but to date, it has not been an issue.
Right.
So next set of questions related to working with the Department of Health at the state level. Two participants want to know if they should contact their public health department to see if this is being done. And one in particular want to know if they can set up a structure or partnership with the aging sector, specifically the area agencies on aging, to reach the homebound.
So that's, go ahead, Ingrid. I was just going to say it's I'd like to know, like, who asked that question and where are they coming from? Are they from public health and local? It sounds like a local public health department person. So Ingrid, I'll let you respond to that.
Oh, sure, and it's basically yes and yes. I would definitely recommend seeking guidance from your state Department of Health to understand, you know, where in your state there's already a strategy set up that you could replicate, or just to get advice, and also to make sure they're attuned to the need for an allocation of Janssen or Johnson & Johnson vaccine is essential to making these programs work. So yes, collaborate and connect with the State Department of Health, and yes, form a partnership with the Area Agency on Aging. And I'm sure, Megan, that you at TIFA could provide lots of advice and support about how to bring together aging and public health.
Absolutely. Thank you for the plug. We're happy to do that. And Ingrid, this kind of just a piggyback on that question for you. A question for you is for local health departments that are just getting started in developing strategies and plans for getting vaccines to those who are homebound. What's your advice on first steps and kind of building that infrastructure that's necessary and building capacity?
Start with a pilot. The first step I would say is to go to the Area Agency on Aging, identify the list of who's receiving home care and maybe narrowing it to indicators that they could be homebound. Develop, recruit a team of vaccinators. In our county, it worked. King County is a little different because we are the coordinating entity for EMS. So we have a lot of pre-relationship with our fire departments, but I would recommend for any local health jurisdiction to go to their local fire department. So find that partnership between your AAA, which exists in every community, fire departments, which exist in every community, develop an initial list, train teams of 2 on all the right protocols, get allocation of JJ vaccine, and get out and test your systems.
Great, thank you. Makes very much sense.
Mm-hmm.
Karan, next one.
There are 2 questions related to actually transporting the vaccines. The question is, do you actually plan a day of vaccinations to finish the vial so there's no leftover doses at the end of the day? And getting at the question of, you can't predict how many caregivers or their family members would need to be vaccinated. And there's some guidance on, again, transportation of the vaccines.
Sure, I can help answer that one, although Ingrid and Tom may have some additional input. I think this was one of the very early challenges when there was such limited supply and people didn't want to waste vaccine. And I'm not proposing now that we waste vaccine, but I do want people to start to worry more about getting doses in arms than potentially wasting doses, as we have enough supply now. Even though it doesn't feel like it, we do have doses coming, and I think that it is okay to waste a dose or 2 in a vial if it's going to get you to vaccinate an additional homebound individual. We totally understand all of the unknowns in terms of the number of caregivers and things like that. What you said at the beginning of the question, to plan a day and try to plan out the number of doses that you're going to be giving, it is great. And for sure, the J&J vaccine is an easier one to plan around because there's fewer doses per vial. But I would really, I'm hoping that, especially over the next couple of weeks, the shift will shift to a little less concern about wastage, recognizing that we do know there will be wastage, especially if we're reaching those who are the most difficult to reach to get vaccinated.
Thank you, Amanda. Other panelists?
No, just that right now we're very, very good about knowing who we're going to be vaccinating. We ask, are there caregivers that want one? And need to make sure that we give them 2-hour windows as to when we'll arrive, and just to make sure that everyone's there and it's not been an issue. And one of the things that's nice is the government pays for the vaccine. And again, none of us want to waste any. In fact, that makes me cringe a little, Dr. Cohn, but you're right that when we have enough, it's more important to get these into people's arms. And if you have to waste 1 of 5 doses, that's not horrible. And the other nice thing just right now for us is that the government's paying for the vaccine. So as you're paying $40 for that shot, you're not losing even more because you're wasting vaccine that you paid for.
Great advice. Thank you.
I'll just add that, our wastage numbers right now are so incredibly low. They're less than 1%, which is, we always anticipated wastage would be about 5 to 10%, which is what you see, especially internationally, when you do these mass vaccination programs and things like that. And so, I commend everybody because I know it's been such a critical issue. And I still cringe a little when I say it too, but I think we're moving to sufficient supply to be able to support that.
And we've heard from a couple of health departments that we've been interviewing that in some states where eligibility is restricted to those 65 and over or 60 and over, that in order not to waste, that they were actually going against some of the state policies to make sure that they were using vaccines. So it sounds like they're, everyone thinks that's probably a good idea to go ahead and get as many vaccinated as possible, even if it means not completely complying with the regulations in certain jurisdictions.
Yes, absolutely.
Thank you for affirming that. Great. And Ingrid, did you have a response to that as well?
No, just great to hear from you, Dr. Cohn, about supply. We do hope we're entering into a different era. It has been absolutely 100% the biggest barrier to our getting the work done at the local level is the lack of a stable and robust supply. We see it starting to change. It's super exciting. We do have a leftover dose policy, and it is to avoid waste and to start with highest risk first to try to use those leftover doses. And then at any rate, to go outside of phase if necessary to avoid the throwing out of any doses.
Yeah. Great, thank you. Karan, I think we have time for one more question.
Okay. This is related to the people actually delivering the vaccines and some challenges that people want to ask about. So one aspect of the question is it true that pharmacies cannot give the vaccine to a third-party administrator? And there's some questions about using volunteer professionals to go in and give vaccines, but concerns about malpractice insurance, and then also challenges with home health administering vaccines. So the questions are all related to how to address those challenges.
I'll add to that too, that, one of the applications, this has actually caused problems for getting vaccine in the home. But I think, Dr. Cohn, it would be, good for you to know that some of the applications state in bold letters, vaccines must be shipped to the location where they will be administered, because they don't want them to be diverted. They want them to get to the people that they are getting to. The problem with that is because of fear of losing their vaccine ability for future, they haven't been willing to give them, even if it's an office where one of their patients is homebound, they've not been willing to give us a dose to give to their homebound patient for fear they're breaking that rule. And the reason I bring that up is that would explain why pharmacists would definitely, with the vaccines they're giving, not give them to go to a homebound patient if they're under that, under that rule that it has to be given in the office where it was delivered. And then, the cold chain we kind of talked about, it's basically, there are these data logger thermometers. They're about $150, which again, with this low volume at home is just another cost that we are using to make sure that during that 6 hours, we keep it within that time frame of the 36 to 46 degrees. And the CDC website has good information on how to kind of do this.
Great, thank you. And I'm afraid we're going to have to stop there. Could we go to the last slide, please, in the deck? And I just want to thank all our three panelists, Dr. Cohn, Dr. Cornwell, Ingrid. Thank you all so very much for all that you're doing, but especially for the time you spent here today. It's been just invaluable information and very, very helpful. For those who submitted questions that we didn't get to, we will endeavor to answer those and share those as well when we send out the slides and the recording. Our policy brief will be published in early May. This webinar recording will be available on our Age Friendly Public Health website. You can register for our April biweekly huddle calls. It was just, the registration was just placed into the chat on April 2nd. This week, we will hear from Donna Walsh, Health Officer at the Department of Health in Seminole County, Florida. who again has operationalized getting the vaccine to older adults. And then next week on Wednesday, we'll hear from Dr. Tom Lally from Bloom Health, a home care provider that has done really, again, some more innovative work. So thank you all, everyone, so much for joining us today. We wish you the best, stay safe, and hope that you will join us for our huddle calls and for the next webinar, whatever that may be. Thank you so much.